This is the Owens Recovery Science Podcast, hosted by physical therapist Johnny Owens.
All right, welcome back to another Owens Recovery Science Podcast. This is Johnny Owens. I'm here with Kyle Kimbrell, and I hope everyone's staying safe during this really kind of scary time. It gets scarier every day. So obviously we're recording this while we're still learning what's going on with the coronavirus. But everyone, I hope you're safe out there. And we're trying to just bring as much good content in case you're trying to catch up or you're bored or whatever. But today is a podcast that's going to be an essential listen because we have a couple of amazing guys who are doing just really cool work. If you're interested in how blood flow restriction is being done in a team setting, especially in the NFL setting, then this is the one that you're going to have to listen to. And we're talking with the staff from the Los Angeles Rams, and Reggie Scott is with us. He's the Senior Director of Sports Medicine and Performance. I've known Reggie for quite some time now. An amazing guy. I'm just going to do his bio. His bio's like it seems like every guest we have on, Kyle, it's like, okay, their bio is like 10 pages long with all these awards and things. You have to shorten it up. So I'm not going to do it justice, but he's been with the Rams 11 years. And so Reggie was actually with the Rams when they were the St. Louis Rams initially. And like I said, now he's the Senior Director of Sports Medicine and Performance. He joined them in 2010, and Reggie became the youngest head athletic trainer in the modern NFL era, which is pretty cool. I didn't know that. He's obviously been through Super Bowls, on the Rams alone, 21 Pro Bowl selections and 2 number 1 draft picks. Currently, Reggie's also the president of PFATS, which is the Professional Football Athletic Trainer Society. He knows how to do crisis management because when they moved out to LA, he was running 3 separate training rooms at one time. And I know I visited him out in the hills up there in sort of northern LA. I thought they were going to be kind of like in the southern Los Angeles area. And I think my hotel was an hour away from where you guys actually were because I didn't know which facility you were at. So they were named the 2015 NFL Training Staff of the Year. And also before this, Reggie's been in Super Bowls with other teams. So he was with the Carolina Panthers, which are good friends of ours. Been some changes up there as well with what's going on with all the coaching staffs and Tampa Bay Buccaneers. So right off the bat, Reggie was dealing with 2 Super Bowl contending teams there. And he went to the University of West Virginia, which I didn't know as well, man. Big 12, baby. There we go. All right. And then Jon Hernandez, who I've known for a while as well. First time I met John, it was in, I think, freaking February in Buffalo, New York, when he was with the Buffalo Bills. And I did this, I did a post-Super Bowl kind of, I went and did the Steelers, I went up to the Giants, and I went to you guys, and that was all in February. And a South Texas guy should never do that trip because I thought I was going to die of cold. And John, too, he's a Southern Cal guy, so he wasn't in Buffalo super long either.
Yeah. Winters in Southern California a little different than winters in Buffalo.
A little different, yeah. So he's been. I can't believe it's been this long now, John, with the Rams for 5 years now. That's very cool. Was also actually before Buffalo at Carolina, and I didn't know this either, man. You undergrad at University of Delaware?
Yes, sir.
Cool. I was just there last month. I presented at their sports medicine conference. My first time there in Delaware.
Oh, so, cool.
We went to that little strip down off of campus. It's almost like 6th Street in Austin.
Yeah, Main Street. Yeah, that's where it goes down. Yep.
I felt old, man, but I got it down. I barely made it home to my hotel that night. But yeah, it was good. And then obviously,
Johnny, I'm from Delaware too, man. So
Delaware too. The smallest.
From Delaware.
I think San Antonio's as big as y'all's state, and both you guys are from there.
You get top to bottom in about 3 hours. So yeah,
got like all the Fortune 500 companies are like registered there. But University of Delaware was beautiful and really cool to see. So I had fun. And then John was at the University of Southern California, which, as everyone knows, we do a lot of work with as well. So welcome, guys.
Appreciate it. Thank you, man. Thanks for having us.
Yeah,
thank you for having us.
Have you guys on. We've been, we always talk a lot offline, and we learn a lot from you guys, and I think we're able to share new stuff. You guys are one of our teams that are kind of like our, hey, let's see what new things the Rams are doing, so we can kind of learn and see if we could, maybe look at should this be studied or not. So first things first, though, a lot of people are kind of wondering what's going on with the NFL right now during this crazy time, other than being locked down from as much as you can share inside the training room kind of perspective.
Yeah, absolutely. I think the the NFL, led by our chief medical officer, Dr. Sills, has really done a great job of, guiding us during this time. I mean, what a tough time we're all dealing with. And, the number one thing we all look at when we're going through this is, what's essential and what we need to do. And outside of that, what can we do virtually? And tough thing about us, Johnny, is doing rehabilitation. It's hard to do virtual,
Yeah.
And so when we sat down with it, we use DICON, which is Duke University's infectious control outreach network, who's phenomenal, and we really get great information from. So we dealt with them, and they put us in what's called an essential medical mode, where we still can do anything that is essential medical, acute stuff, post-op stuff, and that's really nice because it lines up a lot too with a lot of the kind of global CDC guidelines for medical. All of our doctors and stuff, they're still seeing post-op cares and all of that. So that's kind of the state we're in. So we're getting a few guys in. We're trying to obviously monitor symptoms and keep our distance best we can. And, we're having BFRs and running from them. So keeping it going. But that's kind of state we're in. So we're fortunate we still can help the guys out and get them ready for our 2020 season.
And DICON is NFL. Everyone's following these kind of same guidelines, I guess. It's not just the Rams.
Exactly. We got to affiliate with them basically through our union, NFLPA, and the NFL, that group agreement, the CBA agreement. We use DICON as our infectious control call it company, if you will, that we use. And they're great. So we can lean on them not just for this whole COVID pandemic, which has been great to lean on for that time, but for all of our different infectious, protocols and procedures, MRSA, any type of infection stuff we get, flu season. So really great company. We're really excited to have Dr. Anderson and those guys on board with us.
Yeah, very cool. And it's so different. I talked to one of the NBA teams yesterday, and basically they're just like, everyone go home. They're dealing with like 10 guys. And so it's way different from y'all's perspective. I remember one team doc who's a team doc for the NFL and the NBA. He said he did one surgery in the NBA that whole year. He did 36 surgeries in the NFL for his team. So you guys definitely get a much bigger hit from that injury perspective, especially the post-surgical kind of big surgeries.
Right. Yeah. And that's the big thing too, is, right now, the next steps that we're trying to deal with is just coming on with how we do the onboarding process and stuff like that. I mean, you think about it, how many guys we have on our team. So when we get started, how do we onboard? How do we, screen? And then what's our emergency action plan if somebody does have it? So just can't say it enough. Shout out to all the healthcare people and the, people in the infectious control world and stuff they're doing for us, man. It's really amazing during this pandemic time. So definitely really appreciate it.
So we barely got in the NFL Combine, so unfortunately, you guys, it's crazy that was snuck in right before all this happened. But now what do you do with all that data and all those guys you're supposed to be bringing in right now? And it's crazy.
We're doing telemedicine. I think we all know this is changing the world in a lot of ways, and I think we're learning a lot of different things. So like even our rechecks we're doing through telemedicine now. We're literally using Zooms and different FaceTimes to look at guys and trying to look at range of motion, look at videos of those guys doing specific training drills and stuff like that, and then we're uploading it. So we're really changing how we're doing our draft process right now medically in the past 2 or 3 weeks because we can't see these guys. So the draft is going on. We're going to get it ready. And so we're trying to get as much medical information we can remotely compared to in the past.
Well, maybe shutting all these guys down, all those Jones fractures and stress fractures y'all pick up on these guys at the combine, they'll actually heal because they can't do anything.
That's exactly right.
Yeah. Stay away from all these crazy, high performance places y'all go to. And
man, incidental findings every time because of people going, doing stuff they usually don't do. They're used to doing basically,
Yeah. So let's kind of get into blood flow restriction because I know a lot of people want to hear that. Feel free if you want to announce this is exactly when the NFL is going to start. If y'all want to give any of that information, that's great.
Any fantasy football tips you have, we're definitely down to get that.
Let me call ESPN real quick and give them hey, Woj. All right. So, but yeah, Reggie, so years now, I can't remember exactly when we all linked up, but we started, we did worked with you guys, a private training down there, you kind of showing y'all's collaborative effort. Y'all even had some of the Cirque du Soleil people there as well. John Myers was there, who's a really big name, works with the Clippers and that whole organization now. So kind of shows the Rams already are collaborative in the way they do things. And so you just kind of let's talk about rehab first. And we're going to talk about some of the recovery type stuff and other things y'all are doing. obviously you're using blood flow restriction for rehab, but you can just kind of just give us a flow of, an injured person, what kind of injuries we do it on, when we start it, what we're seeing, et cetera.
Yeah. I'll kind of jump off and kind of give a global view. And then obviously I think Johnny can definitely jump in there too. Obviously one of our physical therapists on staff, and really, I give Johnny a lot of credit. He's one of the forefronts of really bringing it to us. I obviously used it at Buffalo and he came to us, and obviously I knew about it, was still trying to fill it out a little bit. I think that's the big thing people, when they first heard it, is, how safe is it and stuff like that. And Johnny was all over it, and then we brought you guys here. So, and we've been using it now for, gosh, John, how long now?
Since we got here, so 4 or 5 years. 5 years,
and he had absolutely exploded with it. So, but globally, Johnny, looking at this thing from a rehabilitation standpoint, probably the primary area for us is a lot of our lower extremity stuff. We have a high level of lower extremity injuries. So obviously all of our post-op stuff, ACLs, all of our knee stuff, our surgical stuff in the ankles, Achilles tendons, obviously our high ankle, even post-injury stuff. Obviously, soft tissue too. I think it's a big component of us. We use it there from a rehabilitation standpoint, from post-injury there. Upper extremity-wise, probably yes, we do a lot of it with our labor and pathology stuff. But just based on demand too, we just we have a lot more lower extremity injuries. So that's kind of the world we use it in. But it is a daily regimen of our rehabilitation. It's in everybody's progressions, and it's been a game changer for us from a standpoint of it truly does allow us. I call it basically a rehab hacker. It really allows us to do things before we can do things, and there's not too many things out there that I would call a rehab hacker. And I tell my staff, and I tell my athletes all the time, it's probably in the last I guess 15 to 20 years that I've kind of been doing this. Two things that I can think of is, unloaded running, right? The Alter Gs, the Hydro Works, and I think VFR are probably the two things that truly have hacked rehab and allow us to be really creative and get ahead and do some things in a safe manner. And so we're really, really cool about that. Johnny, you want to get in a little bit of specifics of some of how we do some of that stuff from a physical therapy standpoint? I think it'd be really cool.
Yeah. Like Reggie mentioned, a lot of the stuff that we do, BFR is, inherently incorporated in it. When players hear that sound, like, okay, yeah, I know I have BFR, or they say they're kind of waiting for it almost as well, because they know it's going to be part of the regimen because they see other players using it, and they know, it's on the horizon. So, like Reggie mentioned, we use it for a number of things post-surgically. I think, one thing to note post-surgically as well, the group we use with Dr. Elatrash, Dr. Banfi, and Dr. Patopoulos, I think working with you, Johnny, as well, they have, are a proponent of it as well. So they're even asking, hey, have you started BFR yet? Yes, it's okay to start BFR. We should start this, at this point. So I think that's really cool for us to see on our end that the surgeons are proponents of this and advocating for this, because they also realize the benefit of it, because they see the benefits later on in 6 to 8 weeks. They see a post-surgical ACL rehab, and they see their quad zone hasn't lost much since surgery, and I think that speaks volumes to the progressions. And I think overall that makes them feel comfortable with progressing stuff maybe a little bit sooner. Not to say we're necessarily pushing the needle and reinventing the wheel, but if we can improve function early on, can we start to progress a little bit more aggressively? And I think they feel comfortable once they see that with these guys that are post-surgical, and to have them on our side, being able to push some of this stuff, and also the players feeling the benefit of it as well. It's hard to BS to players, but when they're just about to tap out after that 45th rep, they know it's real and they can feel it. And I think that really drives the buy-in, is when players can see it and feel it, they're pretty bought into, any kind of sort of rehab and a modality might introduce them to. And BFR is definitely the one that, takes the cake when it comes to really getting the buy-in from players.
That's what's nice, is you've done something. There's never like well, I wasn't sure if I did anything, because it and the player knows it. If it's done right, by that 45th, 50th rep, they should be feeling like you're doing something to them as well. So And I love your point, having the orthopedic group on, Curlin Job's been friends with us for a long time and have really helped us kind of push this along. And, a lot of clinicians out there that aren't tied to teams, I think we can get that synergy, and the surgeon's like, hey, have you started your BFR? And you're talking at the patients, hearing it from both sides. That really helps the buy-in, because BFR is hard. It sucks. And so I think sometimes patients, they hear that ding, 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 ding go off. They're like, oh, no, man. I thought I was on. I thought it's a Tuesday.
Perfect. That was perfect.
I've heard that ding quite a few times.
You're deflated.
So how quickly, like I said, I know Curlin Job's been at this a while and they're pretty comfortable, but say a typical post-op ACL, no issues. How quickly do you guys typically see that y'all are starting it, or Neil or those guys are wanting y'all to start?
Oh, I mean, for us, as soon as they hit our training room, you guys are, I mean, they're, I mean, I'll let Johnny jump in there too, but yeah, we're throwing them on them right away. And, when we're starting our table movements with our quad sets and things of that nature, we're using it right away. And so that's the great thing about it. When we start our, straight leg rate program, stuff like that. So early acutely, we're using it right off the bat. And it's amazing. You can just see that activation component of it, which is, I think, we'll probably talk down that road there, but I mean, it's cool, amazing. Just, we're not, we look at it so much from a hypertrophy standpoint, but I think even from that, just that, that type 2 muscle recruitment that we get early on is really cool. And so we use it pretty soon. What you say, John?
Yeah. I think especially for, post-surgical cases of the knee, and also distally, if you look into the ankle, say we have a player who had a tightrope procedure, or, a RIF distally into their ankle, being able to do proximal strengthening and be able to do some of those things early on with the BFR with low load, we've seen really great benefits from. And, once, especially kind of going back into the bone remodeling and bone healing portion of it, guys who are non-weight bearing and have to wait to put their weight down on the ground, to be able to maintain some of the muscle hypertrophy and strength, and mitigating some of the atrophy, I think is really important once they hit this milestone of, yes, I can start to progress weight on the ground. That seems to go a little bit more seamless in regards to, everything's a little bit more activated and everything has a little bit more girth to it than it did if it was completely atrophied. And we're trying to mitigate some of that stuff. So again, going back to being able to get those functional milestones a little bit more smoother, I think is really cool to see. With BFR.
And the lower leg component is really a big one. So the most injured long bone during the wars is the tibia. And so we were doing this primarily on people with lower leg injuries initially. We weren't having nearly as many, knee problems. It was all ankle fractures, tibia fractures from these IEDs that would blow them up in their Humvees and things. And so preserving the calf was huge for us. This is something you never see. That cam boot comes off and the patient has a freaking tibia for a calf muscle, And then from a performance standpoint, the calf is such a power producer in athletics, and also decelerating the tibia for cutting and things like that. So it sounds like you guys are using it quite a bit in these lower leg injuries as well, ankle fractures and things like that. Yeah,
I think the cool thing about that too is, and I talked to Kyle about this. We had a talk about a couple of weeks ago. Is even the bone remodeling of that. Like, it's funny you just talked about the fifth metatarsal fractures. We have had a couple. And we have one now that we're dealing with that we're even seeing what kind of bone benefit we can get from it. Getting some of those them bone markers to help with healing, along with increasing some of these kind of bone reabsorption markers. So, we're looking at it as we're getting this calf and getting, some of these things going. You got these RIS, or we got these, and, fifth metatarsal fractures, Johnny, those suckers are tough to heal, man. I mean,
they are.
They don't have the bone, the blood supply and stuff that we need. And so that, we're thinking in our head too, that, we're increasing our BFR dosing, sometimes too, like we talked to Kyle about this, doing it twice a day, just hope to maybe be getting stimulate some bone remodeling, factors with it. So I think that's even a cool another nugget that we're getting that benefits from that,
Yeah, that's what I said is this like twofer. like, okay, I'm gonna do this. And by the way, we're going to hopefully keep your muscle quantity and quality. But at the same time, maybe we're also getting this extra bone benefit, and more data might be pushing us that direction. We always kind of talk about Brad Lambert's ACL paper or study that's wrapping up that showed preserving bone. And that was the big thing for us at the DOD is everyone had a bone fracture. And so, our biggest funded trial is a femur fracture trial. So we're hoping all the studies are on dang hold right now. But we also have a stress fracture trial and an ankle fracture trial. And now also we work with Bob Anderson up there at Bellin. And so we're hoping he can kind of get some studies going. He has such a high volume of these met fractures to see, do we need to do it twice a day to really, in the early phases, to stimulate some bone? It'll be pretty cool. We're actually writing a book chapter for Bellin right now. So that'd be awesome. Cool stuff. Yeah. So what about, and the cool thing too is you had really good buy-in on the strength side of the house. So Ted Rath was there, and now I'm supposed to be in Philadelphia next week with Ted. That's not going to happen now.
He called me, asked for your number. I said, "Oh yeah, he's taking it to Philly with him." I almost gave him the wrong number. I was like, "We got to play Philly this year."
Yeah, I know. Well, that's what happens. You guys spread out and starts proliferating. So all this knowledge is going to go out no matter what.
Good for Owens Recovery, that's for sure. Bad for the Rams, right? Gosh, another stuff. So, but no, that's probably one of the, obviously I think rehabilitation, as we all know, is the home run spot for BFR. But I think one of the cool things with I'm really been fortunate with a great staff and stuff that we really thought outside the box a little bit, and it really resonates with us to use this from a performance standpoint. The areas that, obviously when Ted was here, obviously he's going now, and we just got in Justin Levitt from Purdue. He's all super excited for it too, is how to use it in a performance state. And we talked a lot about that, Johnny. And our big home run spots is how can we use this as a potential deload for guys from just a deload week or a call it, when we're periodizing guys and we're getting that week, we want to bring them down a little bit. What can we do and use that? And so we use that a lot for some of those things. Obviously, from a modification standpoint, it's been awesome, right? In our business, what we're dealing with, you got the arthritic knees, the ankles, a lot of different variations there. You got some, low back stuff that we're doing with some of our big guys that we have able to decrease load, right? And still get some of these, hopefully hypertrophy effects that we want. And also too, the feeling state these guys feel like they got a good pump in. I mean, we all know it's anecdotal, but that's really important, for these guys from a psyche standpoint. So, using it there and being creative there is really exciting. We get our new facility. I keep telling you, I really want to figure out how we can, rack system, stuff like that, where we're really BFR as part of our performance training side, just as much as it is rehab side.
Yeah. Very, very cool. Can you talk about a little bit of like maybe some of the force plate testing that I heard you guys were doing with using ischemic preconditioning and stuff like that? We've talked about ischemic preconditioning in the past.
Yeah. It's cool. When I was doing a little bit of research on ischemic preconditioning, I reached out to Kyle to, send me a couple of papers, and, it was funny because it was all, science and all this stuff and way over my head. Science. So it took me about a few days to really, wrap my head around it. But it was cool to, kind of grasp that and then be able to apply it with some of the things that we're doing. One of the main things that we try and incorporate it with is, pre-activity or pre-practice, and using those same principles to be able to warm guys up or help to facilitate that warm up. We always talk about, getting the blood flowing and moving around. What better way to get the blood flowing than to stop it, and then your body, give you more blood. I think is really cool, and trying to reinvent how we think about a true warm up. So I know the setting on the BFRs, and I know the literature talks about 3 rounds of 5 on, 5 off. I won't kind of go into the details of it, but we've modified that a little bit to be more conducive to pre-practice warm-up times, because sometimes that time frame is a little bit shorter. And we've gotten awesome feedback from the players. Players who come in and say they have heaviness in their legs, or it kind of takes them up until, say, the first period, which is about 30 minutes into practice before they start to feel like they're going. They start to feel that right away. And that's within, maybe a fraction of the time that it takes to do a full IPC protocol. And to get that feedback from multiple players, multiple skill position players, multiple players that put a lot of volume on their legs, probably putting about like 5,000-6,000 yards on their legs, for them to feel fresh right away and maintain that throughout the whole practice, really spoke to them and spoke to us as well. So to get that feedback was really cool. Guys started to catch on, it's kind of same with everything. They see someone do it right before practice, like, hey, what's that? Let me get on that. And then that kind of helps the cycle of the buy-in. And then again, then they start to feel it. And then, they're truly bought in. So, it's kind of that mental cycle of, hey, what is that? What's this player doing? What's that guy doing? Let me give it a try. And then, we don't try and push it. We try and have it speak for itself, and the results speak for itself. And once they feel it, we're confident that they like how they feel afterwards. And, obviously we have some guys that say, what, that I didn't quite feel right. That didn't quite feel as good. But, to kind of go back to the force plate stuff, when we use force decks for some of our return to play testing, as well as track fatigue, guys would warm up just on the BFR. We kind of did this anecdotally, just a little bit of a, in-house experiment. And that was their whole warm up. And they're compared to a traditional warm up of just say bike and, some mini band stuff, they actually jumped better just, with the BFR. And, to see that, are you truly really getting, call it, type 2 muscle fiber recruitment, and you're doing a powerful movement. Maybe you're just being able to recruit those fibers a little bit more effectively, so that with this power movement assessment, you're looking at it, you're truly getting a good assessment from that. Or, is it just, you're really getting the muscles warmed up and you're getting blood flowing, as you can say. So, kind of things we just messed around with, but so far we've seen really great stuff with it.
That's cool that you actually have the force plate data to see this kind of objective measure that they did go up higher. They're good. We always like, is there a placebo or something? You definitely know if you had IPC done to you, you had something done to you. But it is still, that's a pretty objective measure. And I like your point. A lot of guys really, it felt like it helped them. A couple of guys are like, hey, I'm not sure, and we talked about this one study, and I know Reggie and I talked together, a while back when you were starting to implement IPC. Probably one of the cooler studies that looked at it from a does it enhance performance type of thing. Olympic swimmers who were very dialed in on their times, if they did it pre 400 meter swim, on average, the whole group got better, 0.8 milliseconds faster. But when you're talking about super elite athletes like what you deal with, significance in a study doesn't matter. Because, it's the most minimal detectable change that you have to pick up. And when you tease out all that data, some people actually, they didn't do better when they did it. But there were the majority, and there were some that they did like extremely better. Like one guy would have come close to Michael Phelps times after doing this. And so if you're able to do it and you pick out, like on force plate, like this guy's a responder, and we don't know the mechanism. We still are trying to figure that out. But if that guy's a responder, then that's like money in the bank for like a pre-event, pre-game type of thing, because you're really enhancing performance legally. as far as we know. I'm hoping WADA doesn't come down on this, one day. But
I know. Yeah, you guys got no chance in a few years' time when WADA starts coming. Yeah, trust me, they see that all the time about this thing. They're like, yeah, this is obviously all the the growth factor, the growth hormones, and all those growth factors that come in there. So yeah, you guys are living on the edge, right?
Well, I had a player reach out who popped hot, and I guess he read some of the literature, and he was asking me if the BFR did it, and he tested positive for a steroid, and I'm like, no, this was an exogenous steroid they picked up in you. BFR doesn't put drugs in you, man. So yeah. That's very cool. Yeah. Yep. What about posts? Do you guys do any like IPC recovery post or movement post with BFR to help with that kind of vague term recovery, but basically getting your guys back faster?
I can kind of Yeah, Reggie, you want to talk about maybe like some of the like the recovery stuff from like Thursday practice, and then I can kind of hit.
To kind of get the specifics. That's great. Yeah, so absolutely same thing. I think from the pre-activation standpoint, the other side of it is the recovery side that we really found a really cool bang for our buck. At this point in time, we've termed them the personalized Normatech, if you will, right? It's like the custom Normatech. It's kind of the cool name that we all say around in our training right now, but basically. We obviously kind of use some of the same settings, the IPC stuff that we can get these guys down and lay them down and get those cuffs on them and just do a quick recovery with them with the cuffs. And the anecdotal feedback that we're getting from these guys is, they feel like once they take the cuffs off, they're getting just this perfusion of blood. Their legs feel fresh. Some of these guys talk about, I feel like they didn't even practice. So just a lot of that positive feedback. And I can't say it enough. You kind of nailed it. When you're talking about elite athletes, they're so in tune with their bodies. And I always tell people all the time, when it comes to our products that we use, people come all the time and say, hey, we got this, we got that, you got to use this. And I always say, they said, what do you think about it? And I says, trust me, I'll let you know if it works, because these players know. And they'll tell you either way, one way or not. And the feedback we've been getting from a recovery standpoint has been awesome. And we started doing it now where on our Thursday, which is our peak day. So, Wednesday practice is kind of a lead-in day. Thursday is kind of our peak day. We'll bring it down Friday, kind of high intensity but low load. So that Thursday post-practice, we really want to start getting these bodies turned over, globally with the guys. So working with the staff, we come with this called post-recovery Thursdays, where we get them in, and as soon as we get them in, we will do a 10-minute active recovery movement by a light bike. And then we will get them in a good postural position. We got these postural beds that we kind of use and put the BFR cuffs on them and get them recovery. A couple of things. We're really big on postural awareness, postural care. I think obviously getting the body in a good spot to almost kind of get a little bit of a sensory deprivation, get the bodies to turn off a little bit by getting them in a good postural position. So you're getting that brain nap, you're getting a little bit of recovery there. And then we had the BFR cuff. So, you're talking about getting this lower extremity, systemic recovery, active recovery. We know all the research out there on that and how big that is. And then obviously having that posture control, we've kind of developed this really cool rhythm with using BFR and getting these guys back. And these guys come back Friday. They feel great going into the game Sunday. And then Johnny had some other cool things, I guess, from the recovery standpoint that, you might have saw or see.
Yeah, it's funny. So we started implementing this, and then I listened to your podcast about IPC, and then, talking about that long-term window about, so basically, Reg, with this, there's two windows, I guess, IPC really works in. It's within 2 to 4 hours of about, so, doing pre-practice, or, within 24 hours where you do it right after. And one of the studies they looked at is that they actually found benefits, and they were able to blunt some muscle damage and the effects of, exercise-induced muscle damage up to 72 hours after that bout if they did BFR right after the event. And to me, I was like, dang. So I guess we kind of did it without really knowing we're kind of getting that benefit of Thursday's our hardest practice. We're trying to get them turned over by Sunday. That's within, 72 hours. You're hoping that the effects of a really hard practice don't affect Sunday, but you also need the hard effects of a Thursday practice to really try and get them to their tissue to adapt, for them to hit, higher speeds and higher loads, so that, by Sunday they're feeling really, really good. And for us to be able to implement that, without really truly knowing, some of that stuff, I think that's really cool that, it backs it up a little bit in terms of timing in regards to how we implement it as well. So yeah, we do like a little bit abbreviated version of IPC. And then, on those other days where players have more time, we can do the full cycle of 3 rounds of 5 on and 5 off. And we also do the cell swelling, and again, we leave that up to our players to tell us, like, which one do you prefer. And every player is different, but I think everyone can agree, once you feel that reperfusion from the IPC and have that feeling, that is a really cool feeling players like, for the most part, because they can actually feel that. So I think more players probably lean more towards the IPC as well. And again, I think, being able to manipulate some of the parameters a little bit has been helpful as well. I know maybe not exactly science-based, with the 5 minutes on, 5 minutes off, but, if they feel it, I think even just the placebo mental effect of it is even equally as important and equally as effective as well. So even if we kind of manipulate that, if they can feel that, I think that really speaks volumes for them.
You know, and it is very interesting, like on all the way to the other scale here is, you know, I'm getting ready to do a webinar for the APTA's cardiopulmonary section, and we're trying to figure out, is there a play for this with post-ventilatory patients or even in ICUs, you know, because right now there's so many patients that are stuck in beds and you can't get them up and walk around right now. And they're, part of the problem is they're going to these deep pneumonias, and that's a bigger issue. They're trying to, how can we get these people moving? How can we preserve muscle? So even to that point, but I've had to go into this deep immunology dive, which I, you know, never thought I would have to go down that dive before. But what's fascinating is, you know, there's this whole activation of this hypoxia, and you get what's hypoxia and HIF1A, hypoxia inducible factor 1A. That comes out from hypoxia, and then what you get down from that is IL-6 starts to come up, and you get basically an immune response. And so you have all these monocytes and macrophages that come out. But what that's key for is that's how you repair muscle. And so the body, you know, when they say you exercise and you get a little immunosuppression, and then your immune system gets a little bit more robust, that robustness is your body's way to bring in the muscle stem cells and to start to heal muscle. And so we're always saying, well, we're doing IPC and cell swelling to do protein synthesis and slow down muscle atrophy. But this immune response might also be why, you know, your guys are getting this maybe something extra that's repairing their muscle on top of that. So whatever the case, you know, we're getting so many reports from.
Hey, Johnny, I'm telling you, you just might have found the COVID-19 man.
Yeah. Don't put that out. You know, I'll get a hate mail like, oh, look at this guy. He's saying, yeah.
We can delay the release of this. It's fine.
Yeah. But you know, we're trying to you know, people say recovery, like, well, what are you doing for recovery? It's a massive term. You know, does that mean sleep? Does that mean they're happier? Does that mean whatever? And then, you know, you guys are doing it. If they're saying, I feel better, I'm recovering, this IPC, these windows the blunting of muscle damage could be cell swelling, and we're increasing the protein synthetic rates, could be this immune response, and all the stem cells that you're flushing into these guys makes muscle recovery. But it's pretty cool. It's like tip of the spear stuff, man. It's like at a whole nother level. I wish we could put our finger on exactly what the mechanism is, but if it's working, it's working.
Yeah.
I'm kind of curious, guys, not to change the subject too much, but one of the questions that we get a lot of times is, well, how do you introduce this? Like, let's say a guy comes over from a different team. It hasn't been integrated within that team that they were at prior. Has it become as much of a culture thing for you that people just kind of see it and they're like, well, I should give that a shot because everybody seems to kind of be doing it? Or is there like a specific kind of conversation that you have to kind of get going? Are there ways that you figured out to sort of graduate the implementation of it, those sorts of things?
Yeah, I think it starts with, you know, I think we have developed a little bit of a culture. So there is that awareness that when guys come on our team, they see it. But it's really teaching the why, man. We're big on that. You know, that's one of the things I really preach as you know, in our departments that we're really doing, is that when we do things, we always educate the players. I mean, we'll sit there and stop and have educational moments with the players and break it down to them. These players will buy in. It's you know, you get them to weigh in, they'll get buy-in. So how you get them to weigh in is to have a conversation and explain to them and ask questions. So we really take our time and really stop and talk about things like that. So, hey, I want to throw this BFR recovery on you, you know, well, you know, they don't even have to ask why. I'm like, you mind if I tell you a little bit about it and just tell you why we're doing it? And they're like, you can, I trust you, Reggie, do whatever you want to do. I'm like, well, no, let me explain it to you. Cause I want you to really understand why we're doing this. So I don't even need you to ask me the why. I want to really know, I want you to know what we're manipulating in your body, what we're trying to do. And that really is huge, because then once again, you get, now they come back and say, hey, I want to get that because I know exactly what it's doing, what it's trying to do. And then also they can feel that response. Like, is what he says, is it really working? Is that what's happening? So it's really just education and buy-in. And I think as clinicians, we probably get really caught up in kind of, I'll call it robotic rehab, robotic kind of training rooms where we just kind of go. And we really don't stop to understand sometimes that these players have zero clue sometimes of what we're doing. And I think that's one of our, bangs for our bucks that we use that really helps buy-in.
Yeah, I know, in courses, a lot of times people do this for the first time and they're like, holy smokes, that's really pretty tight. I'm not sure that my patient will tolerate that. And one of the things that I learned as I was getting going was, man, my patients really trust me a lot more than I thought they did. And I think they're tougher than I thought they were too. And so BFR certainly kind of shaped my practice in that fashion. And so, I would agree. The education component, I think, is kind of huge, because people know now, this person's not just having me go through the motions and do this for their entertainment. There's actually kind of a purpose behind it, and they have a plan. And I think that something that we kind of fall down in rehab sometimes is forgetting to outline the plan for people. Like, look, you're at this time point, we're doing this. This is why we're doing this, because we need to get your range of motion before we can really ever start sticking load on you. And we got to let the joint settle, or we got to try to prevent atrophy, or all these different things, and kind of outlining that for people. And then people go, oh gosh, man, this person, maybe they know what they're doing, maybe they don't, but at least they have a plan. And now we can kind of see, is that plan working?
That's huge. Same here. I love that. That's a great point.
Yeah. And I think also just to kind of add real quick with that is also just knowing how to dose it a little bit, and to slowly introduce it. Obviously you don't want to break them off the first time they get on the BFR. So I think just having them try it out for the first time, maybe doing one exercise just so they kind of get the hang of it, and then progress from there, I think is real important as well. Because, I've made the mistake myself of, getting all wide eyed and say, oh, this would be a perfect case for BFR, strap it on. And, I didn't maybe progress in the way I should have, or I picked a load that was, not 50%, maybe it was a little bit higher than that, or not even 50%, 20%. And, for that might have been a lot of load for them, and might have turn the player off towards it. So I think that's also an important component of, player education is also knowing how to progress it and to slowly introduce it.
Yeah, I agree. You gotta be smart about it, even using a different pressure, a lower pressure at the start.
Mm-hmm.
Yeah.
Mm-hmm.
At our base, anytime we started something new, a new program, we just did it on a Delta Force or SEAL Team 6 guy first. And then everybody else wanted it because they thought it was some secret thing they were getting. So that's how we got buy-in.
Always put it there for sure.
Yeah. Cool. I don't want to keep you too long. I know you guys got a busy day. Just quickly, because when I talk to teams, Kyle talks to teams, or anyone, especially, we do these combine kind of updates to the leagues. Everyone wants to know soft tissue. What are you doing for a hamstring strain or a calf strain or something? And Reggie, you pointed out something I didn't even realize about hamstrings are the second most common injury. Is that right?
Yeah. So, I mean, it's, the hamstring phenomenon is always something we're tackling. And, from a league level, globally, we're looking at it. And it's like number one, it's like the number two burden injury. So time lost because of it based on injury compared across the league, outside of ACLs. And so it's funny, for a soft tissue injury, it's a very debilitating injury for our teams. Guy gets an injury, Johnny, you get a high grade hamstring, you get 4 to 6 weeks. It's such a dynamic muscle. We know in deceleration and rotational forces, and
they're recurrent, they just keep coming back.
And the recurrence rates is high. And that's probably one of the biggest burdens, right? Is the recurrence rate. And so, we're tackling this thing hard from a league level. I think a lot of our club level, we're all tackling this hard from a preventative standpoint for sure. Because we know when we get them, it's a debilitating injury, time loss. But also, when you do have them, how can we get them back safely? Be exactly what you're saying, because probably the number one, when you look at the research, the number one reason for reoccurrence rate is getting them back too early. We're pushing them. Mm-hmm. And the muscle and the tissue is not robust and ready to go. And so, you look at all these different things, like we're looking at biologics right now. You see all these people doing PRP injections of stem cells. I mean, we're all chasing this dream of, how can we get this tissue prepared? A lot of things, Johnny, we can protect, right? Shoulder instability, I can put a brace on it, things I can tape ankles. There's just no way to allow us to, what I call, once again, like rehab hack, right? There's no way I can probably hack the system to protect that tissue to get back on the field. Usually a hamstring has to be pretty robust and ready to go. And so, I think, you hit a great question there. And where's this BFR at, and where can it potentially be another hacker for us? And we've played around a lot with it. We obviously, we do a lot of no board testing with our guys, along with force plate testing. And, we got a lot of asymmetries, not preventatively, but asymptomatically, over the years. And so we start looking at some different things we can do. Can we do some BFR protocols with some of these guys? Are these precursors to soft tissue injuries, hamstring injuries and stuff like that? So we've really been starting to look at how we can just do some low dosing of, body weight, hamstring exercise, and we call it PEDs, right? Prescribed exercise dosing based on the metrics that we're getting. So NOR board, let's say we get a NOR board asymptomatic, but he's 30%, asymmetry on one side, get him on a single leg BFR protocol and see if we get a change, see if we get the asymmetry to go down. Not saying that asymmetry is a precursor or not, but hey, it's something. And more than anything, like you said, it's data that we can use, do this and see what we get back later on with the data. And we've done that for a little while. Johnny's done a lot of stuff to lead that. And we saw some pretty cool numbers. I would still in the beta stage of it. We're still not showing what we're getting from it. Obviously, is it really affecting the field, or would I say affecting change? Not sure of that, but really cool stuff that we're starting to see there, and see if we can start dosing some single leg stuff with hamstrings. Once again, on the preventative side. On the injury side, Johnny, you want to touch some of the stuff we're doing there from a just kind of post injury with hamstrings?
Yeah. So similar to even just post-surgical cases, we're getting BFR on guys within 24 hours. And whether it's just cell swelling, whether it's just doing little isometrics that are not putting the muscle fibers in danger of, being that elongated state. I think being able to improve that blood flow, I know some of the research that you guys have put out there as well in regards to scar formation down the line. Sometimes some of that tightness, residual tightness they feel down the line could just be a little bit of scar tissue that, can, maybe be broken up by the improved blood flow and the factors that affect that in the muscle belly and the musculotendinous area. So, I think that, again, with similar to all the other rehabs that we have, especially with soft tissue injuries, this is kind of a big one in regards to recovery, in regards to doing some early exercise with it, in regards to maintaining as well. So like Reggie mentioned, getting guys out there, the rehab isn't really done yet. If you really think about it, they're probably functional. They're probably functioning at a very high level as well. But, is that asymmetry resolved? Probably not. And, BFR allows us to build capacity and build a robust system after they're back to return to play, so that continue to build endurance and kind of build that up as the season goes on, so that it doesn't become a recurring thing. So, once they're out in the field, they stay on the field. So I think building that capacity after even their return to play is equally as important for us as well.
Are you seeing good tolerance on the hamstring injury with the cuff? Any issues getting it on so acutely?
Yeah, no, it's been good. Actually just within the past few weeks, we had a case and we got him on there within 24 hours and had no issues. And again, that's a, grade 1 to grade 2. I'm not sure if those higher grade ones are maybe a little bit tougher because of, the actual pain they have, but so far so good, I would say.
Yeah. Now, one thing I will say, Johnny, with these things too, is we're learning with these hamstrings. We're getting them moving a lot earlier, and more active movement. We're kind of almost bypassing passive range and really getting them moved. I think something there. We're with it. Even on the field where we're doing marching progressions and stuff like that, we're being a little bit more aggressive with them on the front end, which I think we, personally us from our world and with the Rams, we were kind of letting that tissue lay down a little bit, that acute stage, letting it out. We're early in the acute stage moving them. And I really think that's been a game changer when we're laying down these new fibers. We're laying them down appropriately, but we've been using BFR with that. So I think we're, once again, anecdotally thinking, theory thinking that we're getting this, like he says, we're getting this perfusion and scar formation loss decreasing, and we're getting better tissue laying down in theory, we think. Yeah. So almost like the movement with BFR early, we think we could be, I'm getting a little secret sauce here. So, but
yeah. Well, and there's a slide I use all the time. It's from one of our lead scientists at our base, big BFR, one of the guys that really taught me a lot of it. And a rat model. He put a soft tissue injury on the rat, so basically inflicted a wound on the muscle, and didn't let the rat move for 6 weeks. And it was just amazing the amount of scar tissue there. And then he's got a second histology set where the rats, when they forced them to run at week 1, basically 3/4 of a mile, and kept running, forced sprints almost, the muscle almost completely remodeled, which is, so you got to start thinking, like, what am I doing almost at that first week? It's like making a rat, don't call your players rats, but making them sprint, 3/4 of a mile and adding 1/4 of a mile every week, sprinting. And it actually had a remodeling effect. And so that's where the scientist was like, I think this is kind of this anabolic signal that, like you said, Reggie earlier, lets you do stuff when you're not really allowed to do stuff.
I love it. That really resonates with me in the trench level in the clinic.
Yeah.
I think that really makes good sense. I'm glad you shared that with us, because that's what we're feeling the ceiling too. Because we get those guys that we move better, and then when you start doing soft tissue work on them later, when we want to start doing some of that stuff, I'm telling you, you feel a lot less of the the scar tissue that you can feel sometimes with those guys. And I tell you, that reoccurrence rate, a lot of times we'll have 2 guys will go out there and return to play, and they'll have these sensations of they restrained.
That tightness,
They got tightness, but they recover a little bit quicker than a acute strain. It's them breaking up scar tissue, right? It's kind of called self-manipulation. So, reducing some of those things, I think, are critical for return to play.
Yeah. I remember, I think it was about 7 years ago, Paul Silvestri at Florida reached out and it's like, hey, man, what do you know on hamstrings with this? And I was like, nothing. We don't get those in the military, really. And he was like, yeah, we're starting to see some interesting things with these acute hamstrings. And he was like what you said, Johnny. He was doing it, almost like 24, 48 hours post strain. And so I think a lot of people are real nervous if you're not used to BFR or getting the cuff, on there. Like I've always said, we're doing this on fresh femur fractures, right where the surgery was, where the IM nail is, and we're not really having any issues with it. So
cool. Getting them moving right away and putting them on there, that's huge.
Have you guys seen that, maybe you're able to start sticking load across that hamstring faster because you've gotten them more active on the field, but then also more active with BFR? I mean, in my mind, that's just kind of how I think it goes. But I'm just kind of curious your experience with that regard.
I feel you're exactly right. I feel that what we're seeing is a better subjective feedback from a patient feeling better. There's this, we're getting, these guys are feeling better quicker because of what we're doing early on. That allows us to, what you're saying is to allow us to do a little bit more load. And we're playing with fire a little bit, because I think you got subjective feelings with hamstrings, and you got what the tissue and what the capacity of the tissue is, right? And so we got to balance that. And it's hard to know what the capacity of tissue. That's what we're playing, and that's the game of, I think, in sports, right? We're always, where this tissue's, capable of handling this load, but we want to push that envelope. I always say be aggressively smart. But I will say the subjective feedback of guys feeling better and wanting to do more quicker, I've seen a huge increase. And because of that, we have allowed to push the envelope a little bit, because I don't know if this tissue is truly capacity ready, because it's not like we're not doing repeat MRIs. I can do anything to know if this tissue is ready. So we're going off the subjective, but it is matching up with when we have done it. We haven't had any setbacks. We haven't had any issues. So to answer your question, Kyle, I hope I did in a way that, we are seeing that low capacity. We're increasing a little bit. Really, I wouldn't even say low capacity. I would say we're moving them a little bit more aggressively. We're doing march progression. We're doing kind of more of high knee progression. We're starting different things on the field. So talk for our progression be like almost like an active range of motion earlier, versus it used to be more passive, more of a static. Let's get the tissue to heal. We're
some active elongation.
Active elongation with BFR early. Yeah. We're noticing our progression on the field, and some of those things are a lot sooner. And then we're still probably loading a little bit later, I would say, in terms of a load management. We do a lot, obviously, eccentric stuff, deceleration stuff, but movement pattern wise, really cool stuff. Really cool.
Just had a paper come out a couple of weeks ago with U.S. Olympic team guys and how they're trying to use some ultrasound imaging to understand that muscle capacity from hamstring injuries as well. So
you know what, Johnny, I mean, I think the world of you when it comes to science and stuff. You're the Coach K of science, man. So one big thing about hamstrings that's really tough for us right now is, I'd be honest with you, it's really our grading scale. I mean, when you look at our grading scale, I mean, grade 1, 2, grade 1, 2, and 3, there's so many variations of grade 1. So I look at ton of MRIs over the years. And I mean, you're talking about when you look at that tissue damage, there's so much variation. And so I really think even from the post ultrasound kind of start looking at tissue and how it's remodeling and stuff, we still need to go back to the criteria. I think we need to really reevaluate what is a hamstring strain and how we grade them.
Yeah, the most recent hamstring or muscle strain review paper actually said that, Reggie. They were like, the grading scale it's kind of all over the map. It's almost kind of not that reliable, even when you image with an MRI, and it's really, whatever the fancy T3 weighted are. It was almost like, if you were skilled in the assessment of muscle strain and a good physical assessment, you were getting just as good a result. And then I kind of referenced that Jack Hickey paper to you guys before we got on. But they looked at pain threshold training with after hamstring strain injury versus not. And what they saw was that it kind of didn't matter. Like both groups, either the stayed away from pain or went into pain with their hamstring strengthening exercises, either returned to play around the same time. They had a similar amount of re-injury. But what they saw is the people that trained into pain actually had better pennation angle and they had better strength in their knee flexors. So, we worry about pushing these people, but it's kind of a worry. It's not really founded in good, hard science. So
it's a cluster. We're having to move into a cluster of findings now, It's kind of like with x-ray imaging of, everyone's like, is the bone healed? And the doc's like, yeah, it's been 6 weeks. It's healed, And so, the trauma, I was part of the group. They had to put out it's called the RUST classification now. It's a whole cluster, Do they have pain when they walk? Is there swelling around the fracture site? You just can't look at the x-ray anymore and say, that's a grade 3. You have to say all these things together. And so that's where the people like us and you guys, especially, they're on the front lines. I think you already know just kind of being around a hamstring where this thing is and how bad a grade it is and maybe what the capacity is, and let imaging also add to it. Well, I want to be super cognizant of your time again. Just last thing on that. Are you guys doing any BFR with the PRP, like pre-BFR PRP? Do you guys do that? I know Orlin Pavasti, KJ, and I have talked a lot about stuff with that. So anything down there?
So, I think in our setting, it's a little tougher. I know me and you talked a while back with that, and I thought that was really cool to kind of do that. Most of our cases, I think, in the world, when we're using PRP, right, we're using PRP probably in season, right? We're trying to hack the system to get back a little bit sooner. So typically our PRPs are Monday after game. Obviously, guy has guy's an injury, and within pretty much that day or whatever, we're probably going to doing it, and joints and stuff of that nature too. Guy comes in with a hot joint. Dr. Elitros, I think, has been phenomenal in the world of biologics. He's really on the front line with it, and Curl and Joe have done a great job. But guy comes in with a swollen knee. He wants to quiet the knee down. He wants to give a little bit of biologics to it. We're probably doing it right then and there. So I think based on our environment and how we're using biologics, we really haven't been able to chance to say, oh, you're using biologics, let's get a couple of days of BFR on it.
Yeah, that window's tight. Yeah,
our windows are so much tighter. So haven't had an experience with that, but gosh, that makes some really cool sense theory-wise. Yeah. And just from that, so it'll be interesting to see what you get over time. And honestly, I'll be honest with you, if some cool stuff comes out with that, and it's talking to Dr. Elitros and talking to our team, if it's something worth sometimes for us to wait to maybe get a little more bang for a buck, that'd be a great new regimen for us to try to use.
Yeah, we're working on it. I was supposed to be down at the new Arthrex facility next month, but that was one of the things I was going to push with Arthrex is, hey, you guys want to fund a big PRP study with us? We'll
that'd be really cool. Yeah, that'd be really sick. That'd be cool to get some of that ACP stuff and look at that and see if we see it a little bit better there. So
for sure,
we're getting pretty good results with it. So it's been cool.
Anything lastly that you guys want to wrap up here with before we get back to the COVID life?
Well, no, I think really at the end of the day, I just can't say it enough, Johnny. I think two things. I think, first of all, the product speaks for itself. It's one of the biggest game changer products, and like I said, the past 15 years for me. So just can't appreciate enough and how you helped the profession of rehabilitation and us. And then I think more importantly too, I think having podcasts like this and just you supporting everything with so much science is so powerful. One of the toughest things I think in our world of rehabilitation and a lot of our products is we don't have a lot of science behind a lot of stuff that we have out there in terms of modalities. We really don't.
Yeah.
Especially a lot of our newer modalities. So for you guys to really keep everything science-based first and really and push it with science is very refreshing, and we can't thank you enough for what you guys do and how supportive you guys are, and more than anything having us today. It's been really awesome.
Yeah, and Johnny, just to kind of add to that real quick, to piggyback on what Reggie said, I think the thing that's really cool is, you guys back a lot of stuff with science, but you also are very grounded in your application and grounded in, what's real. I feel like you guys have a really good comprehension of, what practical application is like, in our settings and in the clinical setting. So I think having that understanding is really awesome to have, because sometimes you can get lost in the science. It kind of gets lost, like, oh, this is this and that. Well, at the end of the day, how do you apply it? How can we use it? And I think bridging that gap is something you guys have really done a great job with. And, can kind of see the progression of when we first took the course. I first took the course about like 6-7 years ago, and to see how it's applied now and how it's being used from first the rehab set. Well, first, from the setting that you started in with the DOD, how it's kind of shifted into the rehab and hospital setting. And now, going to the performance kind of avenue and setting, I think is really cool to see that evolution. So I think that's more so a testament to you guys. So thanks again. Awesome job, guys.
Yeah, man, it's been awesome. Well, next time you see me, I'm going to be glove and gowned and working in an inpatient ward trying to measure immune responses.
You're going to have a hat mask suit on, huh?
I know. I already have one when I go to the grocery store. So.
Yeah, exactly.
Well, thanks, guys. This has been amazing. Awesome. So fun talking to you, and I hope to be out in LA again, and Kyle and I can go hang out and see what cool things you're doing. Yeah. Appreciate it. You guys rock, man.
Yeah,
love you.
Absolutely.
Yeah.
Thank
Kyle,
you.
we want to get you over there, Kyle, but unfortunately we got a social distance, so we'll figure out a time.
I know, man. We'll make it happen one of these days.
Yeah. You're like every girl in LA, social distancing from Kyle.
Make sure they get on the podcast. I'm sure on Instagram and kind of help that.
Hysterical.
All right, man. Thanks, guys.
All right, guys. Thank you.
Thank you.
Thanks for listening to the Owens Recovery Science podcast. Owens Recovery Science is a single source for PTs, OTs, ATCs, DCs, MDs, and other medical professionals seeking certification in personalized blood flow restriction rehabilitation training. Find them online at owensrecoveryscience.com.